Hi, welcome to another video of Trainees. It's been a long time since we have uploaded another video on our YouTube channel. I hope you all are safe and sound in this testing times of COVID-19 pandemic. Myself is Manu. I am an emergency nurse and I'm quite passionate about education and teaching a lot of emergency management of various disease conditions. Today we are going to cover a topic on tachyarrhythmia section and specifically focusing on supraventricular tachycardia. A supraventricular tachycardia is any kind of abnormal heart rhythm which is originating above the ventricles. As we all know, it's quite a large term. It's a huge umbrella term consisting of a lot of disease conditions or a lot of abnormal ECG patterns. The most common ones are the atrial tachycardia, the AV nodal reentry tachycardia, atrioventricular reentry tachycardia, atrial fibrillation, atrial flutter, etc. Now today's video we are just focusing on one of the supraventricular tachycardia, which is quite common in youngsters and also in people without any structural abnormalities of the heart, and that's the AVNRT. So AVNRT means Atrioventricular Nodal Reentry Tachycardia.
AV nodal reentry tachycardia is a very common type of SVT. Usually they do not have any structural abnormalities, so they're quite common in youngsters, and the focus of this conduction problem is the AV node itself or the surrounding cardiac tissues around the AV node. Usually the rate is quite fast. Even though I said the resting rate is 100, it can go up to 150 to 220 considering the adult and the pediatric population. So they're usually very fast, and as the picture that I've shown earlier, this is exactly what it feels like. It feels like your heart is about to pound out through your chest. Going into the applied anatomy and electrophysiology, anatomy and physiology or electrophysiology. So that's your heart, and we're going to talk about the conductive system of the heart. So this is the supraventricular aspect of your heart, and this is the ventricular part. The conductive system, the impulses of your heart usually are generated by the pacemaker of the heart, which is the SA node. Okay, the SA node then leads into, so I'm going to hide this. So we are just doing an online dissection of the heart. So the SA node leads into another structure called as the AV node, and then the AV node leads into the bundle of His. The bundle of His spreads into the left and the right bundle branch, and they split into the tiny Purkinje fibers. Now we're going to talk about the electrophysiology behind AVNRT. So in AVNRT, the culprit is AV node itself. This is the SA node. The impulses are traveling into the AV node. There is a signal delay, and then it gets transmitted into the ventricles. In AVNRT, so we're going to focus only onto the AV node. Okay. People with AVNRT usually have an abnormal pathways. So it's all about electrophysiology we are going to talk about. So they have an abnormal pathway. They have a slow pathway. I'm drawing it. So it's just like a windy road. So you will not be able to drive your car very fast. That's how I remember it. So it's a windy road with a lot of dust and things. So you'll be able to drive very slow. So it's a slow pathway, or S. Then you have a highway which you can drive very quick or very fast. So that we call it as a fast pathway. And then the impulses goes into the ventricles. So this is what happens in people with AVNRT. Under normal circumstances, the impulse from your SA node is travel down to the AV node, and they usually split or they usually conduct these impulses both into the fast pathway and into the slow pathway. If you are able to work very fast, you get tired very fast. And slower pathway, impulses are conducted very slowly, but they don't get tired. So they have a shorter refractory period. Fast pathway have a longer refractory period. So repeat again. So fast pathway has A longer refractory period means they are tired for a long time. Slow pathway has got a shorter refractory period, that means they don't get tired very quick. Impulses, when they're transmitted from atria to the ventricles, they usually travel into the fast pathway and into the slow pathway. The fast pathway impulses get transmitted very quickly down and they go into the ventricles as quick as possible. And some of the impulses will also be going into the slow pathway. And finally, the fast pathway goes into the refractory period. That means it's no longer able to conduct any more impulses. The impulses which are traveling from the fast pathway into the slow pathway gets nullified at the way or at the midway. So basically there is only one impulse effectively transmitted from the atria to the ventricle. You have a P wave and then you have a QRS complex. Everything is good. Now, imagine a person has been taking too much alcohol, too much caffeine, there's too much of stress, your heart is put onto test, patient is having an innate AVNRT happening inside this AV node. So there is this slow pathway, as I've already explained, which has a shorter refractory period. That means it doesn't get tired very quick. And then you have the fast pathway, which get tired very quick. Now imagine instead of one impulse, we are having two impulses at the same time. So this is impulse number 1 and this is impulse number 2. So this is number 1 and that's 2. So two impulses are coming at the same time. The first impulse will travel into the AV node, goes into the fast pathway, goes into the ventricle. At the same time, the second impulse will go into the slow pathway and it starts to conduct slow and slowly and slowly, and it starts to get into the fast pathway before the fast pathway goes into the refractory period. So the second impulse is basically transmitted through the slow pathway. It goes through here and it goes back. Goes through here and goes back. So some of the impulses will be conducted backward and some of the impulses will be conducted forward. So the first impulses was transmitted normally, the second one is going into an abnormal loop. So what happens is at the same time you have a retrograde conduction. So I'll just write it as retro. And also you have an anterograde conduction. So what happens is you're having P wave and QRS happening at the same time. So they get superimposed and effectively you'll be getting a narrow QRS complex like this. So you have a narrow QRS complex with ST depression, narrow QRS complex with ST depression, narrow QRS complex with ST depression, and that's what we call it as an AVNRT, or in other words we call it as an SVT. So the prime feature of an SVT ECG is you don't see a P wave because P wave is superimposed into the QRS complex. This is because this abnormal circus of electric waves being transmitted backwards and forwards at the same time, and that's how an SVT is formed. Okay, now we're going to look into some of the ECG features of an SVT or AV nodal reentry tachycardia. So let's start with the rhythm strip here. So that's the lead 2 rhythm strip here. So if you look into this rhythm strip, you can see that the QRS complex, there are no P waves to start with. That's the first feature of an SVT. So there are no P waves. Okay, you can see the QRS complex is, so I'll zoom in a little bit and show you that. So if you look here, the QRS complex is quite narrow. That means they're less than 0.12 seconds or 3 small squares. You can see there is significant ST depression here. So that's an ECG feature of an SVT because it's a rate-related ischemia because there are multiple conduction of impulses from SA node to the ventricles, which is causing a bit of a transient ischemia onto the ventricular muscles, which is represented especially in the endocardial region, where you can see some ST depression, which represents a rate-related ischemia due to fast beating of the heart. You can also see here, if you just zoom in a little bit here, if you can see that there is a bit of a pseudo R wave formation here. That's because, as I said earlier, this is because of the retrograde conduction of the impulses. The impulses are conducted backwards. That means from the AV node to the SA node. In some of the ECGs, you will be able to see an inverted P wave, especially in the inferior leads in lead 2, 3, and AVF. I'll show you another example. So as we look here on lead 2, so there are no P waves that you can see. But also if you focus here, you can see an inverted P wave, or we call it as a pseudo S wave. Okay, so that represents the P wave is inverted and it's happening after the QRS complex. That means the impulses are conducted backwards. If you look on lead B1, you can see that there are R waves there. You can see there are pseudo R waves. That also represents a retrograde conduction. That means the impulses are conducted from the ventricle to the atria. And also you can see there is some rate-related ST depression. So there is some rate-related ST depression when you compare to the J point. There is significant ST depression, which represents there is a rate-related ischemia. Those are the few of the ECG patterns that you see in an AVNRT. So the management of AVNRT is usually vagal maneuvers. So there is a modified Valsalva maneuver. Basically, what you have to do is you'll ask your patient to blow through a syringe for 15 seconds, and then with the help of your colleagues, you have to raise their leg 90-degree upwards, so that will suddenly stimulate the vagus nerve and reduces the heart rate. So the Valsalva maneuver in the past, where just blowing through the syringe or blowing through the straw, has proven that it's not that effective, whereas modified Valsalva is more effective. The treatment protocol includes asking your patient to blow through a syringe for 15 seconds, and your colleague will raise the patient's foot up to 90 degrees to the torso of the body, thereby stimulating the vagus nerve. Pharmacological management, the drug of choice is adenosine. And then if adenosine doesn't work, a synchronized cardioversion is a treatment of choice. If your patient is unstable, vagal maneuvers and pharmacological management do not have any place. It is best to do synchronized cardioversion if they are in shock, if they are hypotensive, if they have an altered GCS, etc. So if they have a tachyarrhythmia and they are in shock or they are in circulatory collapse, you have to think about synchronized cardioversion at the first instance. If they are stable, you can start from vagal maneuvers, then go into pharmacological management, and finally, if those two are not effective, go into synchronized cardioversion. The drug of choice is adenosine. So adenosine itself is like a drug which has got a half-life period of 10 seconds. So it has to be a rapid IV bolus as quick as possible. On a large bore IV cannula, which is preferably on the cubital fossa of the patient, so that it's very close to the heart. Ideally, if you have the luxury, it should be a two-person job. So one person should be pushing the adenosine, the second person should be giving the flush, raising the hand for about 10 seconds, and you will look for the ECG changes. Usually an ECG change is represented as a flat line or an asystole for a few seconds, and the patient either go back into a normal rhythm or they flip back into the AVNRT. If 6 milligram is the initial drug of choice, if not, you can go up to 12 milligram, and then you can further repeat 12 milligram, even though some institutions they give up to 18 milligrams of rapid IV bolus. Adenosine, you should be very careful with people who are asthmatic. because you have to explain the procedure to the patient that they have severe vasodilatory effects, so they will have headache, hot flushes, the impending doom that they're going to die, and you should be careful in asthmatics because it also can cause transient bronchospasm. The adenosine works basically on the SA node, and they block the conduction of the AV node, and also it blocks the calcium channels on the SA node. So basically the adenosine acts on the SA node, thereby reducing the impulses coming to the AV node. The ultimate treatment for AVNRT is radiocatheter ablation, which I'm not going to discuss through here because I'm just going to talk about only the emergency management. That's AVNRT in a nutshell. I hope the electrophysiology and the management is quite clear. If you have any questions, comments, please do comment on the comment box below, and please do support us. Thank you.